We're here at the 21st CROI, 2014, in Boston, cold Boston, Massachusetts. And we're here with Deborah Prasad and also with Hannah Gay, who have been referred to as working on the, quotes, Mississippi baby, which is much more than that, as we're going to be describing in this brief program. But before we do that, I think it's fair to start with Hannah here, because she's the one that unfolded the episodes that gave us all this good information in science. So would you start with how that unfolded last year, kind of like a little backup to last year?
Surely. So it's a story that we've told many times now, and actually as a team, Dr. Prasad, Dr. Catherine Lizuriaga from University of Massachusetts, and I worked together to explain to CROI 2013 how we had had a baby born in Mississippi in 2010 who was born at high risk of transmission from her mother. And so we started her as post-exposure prophylaxis on 3 different drugs. Soon determined that she had already been infected, so she continued on the medicines as an infected child with anticipation that she would stay on those medicines for a lifetime. After 18 months, her mom quit giving the medicines. And when we started testing after getting her back into clinic, we found out that her virus had not returned. So we were very surprised at that. I called Dr. Lizuriaga, who called Dr. Prasad, and started looking at testing to see what was going on with this baby. And I will let her describe the test results.
That, yeah. And how do we move from there?
So we've been working on HIV in children for over a decade and a half, knowing that once children start treatment, it really is a lifetime of treatment. We have enough experience with our standard treatment that the virus does establish these so-called viral hideouts or reservoirs where it can hang around for years, that when you stop treatment, the virus rebounds. So when we got called from Dr. Hannah Gay, we immediately recognized that this was a different case. And why do I say that? Because the child had been off treatment already for 5 months and had not had return of the plasma virus. And we quickly learned that what was different about this case is that Dr. Gay had started a 3-drug regimen or treatment regimen very shortly after birth, so within the first 2 days of life, at around 30 to 31 hours of age. And so with that, we recognized that that may have been the unique management in this infant.
Before the virus got maybe seeded through all the cells.
Exactly, and so that's what we were working on, is the hypothesis that perhaps by starting treatment this early, we prevented the virus from spreading to these reservoirs, which currently preclude or does not allow us to stop treatment. Now, I must say it's a single case, and as you know, there was a lot of hype around the case. And so we really wanted to be very cautious in a way, because there may be other factors that contributed to the Mississippi baby outcome, other than treatment very early. Now this year, and also the baby had only been off treatment for about 10 months when we reported at CROI. So still a fairly short time to say we're on our way to remission. We're calling this remission, meaning that we've been able to stop treatment. We don't know if the virus is going to come back at a later date in the Mississippi child. But at this meeting we reported, because Dr. Hannah Gay continued to follow the child very closely, we reported on the 23-month follow-up, so almost a 2-year follow-up, that the baby remains in remission with undetectable plasma viral loads.
Now, when you say undetectable, in the press conference we talked about little particles, or can you describe that? I know that's tedium, but...
No, I think it's important to make the distinction. When we say undetectable, we talk about what's clinically relevant. So using the standard viral load assays, less than 20 copies, the baby has remained undetectable. But obviously that's not sufficient to say remission. It may be sufficient for clinical remission. We wanted to dig a little deeper to see how much virus is still present, or is there any virus present still within the blood cells of the Mississippi baby. And we don't detect any evidence that there's replicating virus within the baby, but we do find traces, very low levels of traces of HIV still present in the peripheral blood cells. We know with these assays that there can be low-level signals, maybe even this noise, and so it may represent noise, but it may not represent noise. So we've continued to follow that and track that level of persistence, as we would say, of the virus in the baby's blood cells, because it's important to understand what that level of detection means.
So this is not residual from anything like the mother or anything like that. It's obviously something, either something or not, but not associated with anything from the mother or the original virus.
Yes, that's a very good question. And when we first presented the case, some scientists in the field suggested that perhaps the initial infection events we detected were actually from maternal cells or mother cells still hanging around in the infant's bloodstream. And this is known to occur. So in fact, since the last report, we've looked to see is there any evidence of maternal cells still hanging around in the infant, and at 40 months of age, we have not detected, using very sensitive methods, maternal cells present within the infant's or the child's bloodstream. If this is not noise, then it suggests there's still traces of the virus in the child's system. But the most important thing, it does not appear to be a replicating trace of virus, because when we look for virus that can replicate, we don't detect that.
So how do you look? Do you go down lower than 20, or I mean, they can
Yes,
go
so
down
we
to
do
have
go
a
down. So there are two ways we can look for replicating virus or virus capable of producing RNA that can infect cells. One is there's a viral load assay that's called a single copy assay that can quantify how much virus nucleic acid is still present in the plasma. So we've worked in collaboration with Dr. Mellers, and using a single copy assay, we've not detected any traces of replicating virus. We also, there's a reservoir for HIV in resting memory CD4 T cells, from which we can culture, do in vitro testing to see if we can culture infectious virus from the cells or latently infected cells. And so we've done those assays on the Mississippi child and have not detected any replicating virus.
Would it be, it seems like it wouldn't be of any value to do a cerebral spinal fluid, evaluation, because it probably never got in there, right? Imagine.
It's hard to know. So what you're asking about, is there a CNS sanctuary site or reservoir in this child? And clearly, if the signal we're seeing in peripheral blood cells represent a true signal, it will be important to identify where those cells are coming from. Because we don't see any virus in the peripheral blood, it's unlikely that we would detect any in the cerebrospinal fluid of this child, given that the child is off anti-drug treatment. I think if you're on anti-drug treatment, it's very hard to say that there would absolutely no virus being suppressed in the central nervous system. But off anti-drug treatment, I think it would be very unlikely.
So this child is not identified, right? You're keeping this.
That's right.
But it's doing healthy.
Very
it's doing
well.
healthily. Yeah.
Very well.
All right, and I guess it's now the work that you're doing, does it inform cure research, or cure researchers that are doing this work? Are they taking anything from this?
So I think it's absolutely informing cure research. You may know that we did present a second case,
Yes,
not of remission,
a
a different sort of case than the Mississippi case, but it's a case that was treated similarly very early at 4 hours of age. And in that infant, we've monitored using the similar assays as we've used to look and trace HIV in the Mississippi child. We've looked in the second child, but very early in the time course of treatment and while on anti-drug treatment. In that child, what we've identified is that the virus was cleared very quickly from the bloodstream with very early treatment. Obviously, we can't say remission because the child's still on treatment, and we need to do further studies. So to get back to your question, does it inform science? I think the fact that we've had 2 cases now, and again, it's not similar, but certainly cases where very early treatment has really curtailed spread of the virus, suggests that there is a potential way, at least in perinatal infection or pediatric infection, because we know when children are exposed to the virus or infants are exposed to the virus, for us to be able to intervene. It's a second case, and again, it's not a remission. And then there's a poster being presented by Steve Deek's group of an HIV-infected adult on PrEP who similarly had received treatment very early while on PrEP and identified as infected, and they're finding a similar outcome in that it's very difficult on antiretroviral treatment to detect any traces of virus in that infected adult.
Right.
So there's a common theme here emerging. I think we had the Mississippi case a year ago. We have a second child in California who was treated very early, who cleared virus early but remains on therapy. And now we have an infected adult who received treatment early, who appeared to clear virus. And then there are data at the meeting in the SIV model showing that if you treat within 7 days, it makes a difference in terms of reservoir size compared to even 10 days. So I think there's a common theme emerging.
So we have to find out what that magic number is and where, and maybe it's fluctuating, maybe it's not written in stone, but so if we, the way in which you would treat would be based upon early discovery and testing like you had. I mean, maybe that would be a new standard of care, and maybe we should revisit that.
So what's being done, certainly for pediatrics, because we know the time of exposure, we can, for kids who are high risk, we can empirically start a regimen pending results of testing. And that approach is being studied in a clinical trial that's sponsored by the National Institutes of Health that we expect to open within the next few months. So we hope to get those answers fairly quickly.
Well, it's the essence. I mean, just trying to figure out if this can be really utility in with clinics all over the country. I mean, we have so few children who are born potentially from mothers who are not unsuspected of being positive. I mean, it seems like this is an opportunity to really move quickly, like you say, get this answered quickly.
Well, we still have a fair amount of infections in children globally.
Yeah, globally.
But I do want to emphasize, because the last time we reported the Mississippi baby, there was some confusion for parents in the community with respect to treatment and stopping treatment. And again, these 2 cases are very different than what we've done so far. So it's really still very important that children remain on their antiretroviral treatment regimen. Because we're not at a place of stopping treatment and assessing remission.
Right, this is a completely different situation.
Completely
you should
different.
always listen to your doctor.
Yes.
I know most people, they tell when you're on treatment, you're probably going to be on it for the rest of your life. And that's no bad thing. The treatments are fairly innocuous. Yeah, they work and they're fairly innocuous. And there are a lot of great treatments for children. I mean, the sprinkles and the formulas, the liquid formulation and so forth.
And another point that we need to make again this year, like we made last year, prevention is still better than cure. And so all women, when they're pregnant, need to be tested for HIV. Absolutely. If they test positive, they need to get into HIV care. And with proper care during the pregnancy, we can prevent almost every case of transmission.
Yes, it's a solid message. Thank you for giving that. Yeah. Well, I know that you're very busy at this conference, and I really appreciate your opportunity, giving me the opportunity to visit with you and for our audience, because it's a message that is, we're learning.
Yeah. Well, thank you for giving us the opportunity to speak to your audience about this.
Thank you.
Thank you.